So here you are watching drug-induced sleep endoscopy with this monitoring in a 39-year-old male with history of snoring and choking. Yeah, he has got a deviated septum on the right side in the higher part, and in the lower part it's deviated on the left side. His body mass index is 30, so he's not obese, he's just a little overweight, but he's muscular, he's not fatty. And his AHI is 70, most of which are obstructive apneas, almost 69 AHI. As I go inside, you can see turbinate hypertrophy. You can see a very little adenoid, which is not really significant, but you can see grade 2 salpingopharyngeal fold. Grade 2 by Agrawal's classification, they are coming absolutely close and touching each other. And you can see a predominantly lateral collapse of the soft palate, which is partly because of the tonsil. This is the upper part of the tonsil covered by the posterior pillar. Very clearly seen, and that's the uvula. So predominantly a lateral collapse, but when you correct the lateral collapse, the uvula will also come in. So his uvula is also pretty long. Now at this point of time, I am trying to see the epiglottis and the tongue base. You can see his epiglottis and the tongue base is not really obstructing. It's mainly the soft palate which is obstructing. And he's sleeping with his mouth open. So what I'll do now I'm trying to close his mouth forcibly. He has been a mouth breather since childhood. Now as I close his mouth forcibly, see what is happening. Everything improves and there's no tongue base collapse. The size of the tongue base is not large. The epiglottis is absolutely clear. But in spite of closing his mouth, you can see his palate is still collapsing. Right? So doing a nose surgery only is not going to cure him. His major issue lies in the throat, which is at the level of the soft palate. Now see, that time you were seeing the lateral collapse as being more prominent. Now you're seeing epicollapse is more prominent because I am closing his mouth forcibly. Alright? And the base is in the correct range. So therefore, you always have to, while performing surgery, you always have to perform the surgery both for AP as well as lateral. It was predominantly lateral earlier. Now it has turned predominantly anteroposterior. Now as I leave his mouth open, now we'll see what happens again. Now I have left his mouth open. Let me just come out and go in again. Lot of secretions over there. Now see again, it's predominantly lateral again with the mouth closed. And with the, I'll again, sorry, mouth open. And now I'll close the mouth again, close the mouth and see what is happening. Try to avoid the secretions. Now let's see what is happening. His palate is still collapsing, majorly now anteroposterior. Obviously lateral also. So it's basically both AP as well as lateral, but only in the lower part. The upper part is not collapsing. So it's a good candidate for suspension bridge pharyngoplasty, septoplasty and turbinoplasty. On the CT scan, his sinuses are clear. So that's the surgery for him. Thank you for watching.